Alright guys, I know this is not necessarily how we'd like to get this covered, but with me being out of town on Monday, this is one of the best ways to go ahead and be able to keep going. So we're going to actually finish up the respiratory system through this video. So when you come to class on Wednesday, make sure that you bring your digestive system notes because we will start that on Wednesday. Alright, so where we left off, we were talking about the different structures of the respiratory system. We had talked about the nose, we had talked about the pharynx, which is the throat, the different parts, and we had talked about the larynx. Now we want to move down and we're going to go into the trachea. And the trachea is going to be right down in this area underneath the larynx, which is your voice box. Now your trachea is known as your windpipe. It connects your larynx to your primary bronchi. The trachea is made of smooth muscle, but it also has some C-shaped rings of cartilage, and they sit in this kind of direction. And this is to help make sure that your windpipe does not collapse. We don't want it to collapse. That would stop you from breathing, so we want it to have that structure. This is lined with ciliated mucous membrane so that it can flush out some stuff that if it does get in there, and it moves mucus upward, and that mucus being moved upward is there to be swallowed normally at that point. Not necessarily to cough it out at that point, but to be swallowed so that any kind of pathogen can be taken care of by your stomach acid. Now, one thing to note when you look at this picture, guys, you'll notice that the windpipe or trachea is a larger circle because of that C-shaped cartilage that's here, holding it where it stays open, and it is actually in front of the esophagus, and you can see the esophagus here in the picture. All right, so now again we're moving down. If you'll notice, this kind of looks like a tree. So we've talked about the larynx that you can see here in this picture, the trachea. Now we're going to move into the bronchi or the bronchial tree. The bronchial tree is composed of the trachea. The trachea is like the trunk of the tree, and then we move into the primary bronchi. These have smooth muscle and C rings of cartilage as well. They are also lined with ciliated mucous membrane, and you can see them located here. You have a right and you have a left primary bronchi. Then you have the primary bronchi branches, which branch into the secondary bronchi, and these are going to be smaller than the primary. The right lung has 3 secondary bronchi because it has 3 lobes that this is serving. So there's 1 in each lobe. The left lung only has 2 secondary or lobular bronchi because it only has 2 lobes. These secondary bronchi then are going to branch into the tertiary. The tertiary bronchi are also known as the segmental. There are about 10 tertiary bronchi in each lung. Okay, so as you're going through here, it's going to spread, and there's about 10 of these. These then divide even further from the tertiary bronchi to the bronchioles. The bronchioles then branch even further, and the bronchioles are the tinier branches that you see here. Once we get to the very end, these bronchioles will actually end at what we call the terminal bronchioles. Now remember, terminal means end. Now there's no longer any ciliated epithelial here. It's just simple cuboidal epithelial, and instead of having the cilia to help get rid of pathogens and sweep it up, we're already too low in the lungs, and so instead they have macrophages that are here monitoring and trying to kill any invaders when they get into the deeper part of your lungs. You'll also notice that their cartilage C-rings have gradually disappeared as we have moved down, and the amount of circular smooth muscle has also gradually decreased. And the reason is that muscle helps be able to bring the air in and push the air out, but when we're down here at the bottom, we're switching gears. Remember that this all above was part of the conducting system. Now at the terminal bronchioles, we're about to get into the respiratory system where the gas exchange is going to take place. Alright, so when we look at this, guys, smooth muscle of the bronchial tree is innervated by the ANS. Remember, ANS is the autonomic nervous system. During exercise and during emergencies, the sympathetic division of the ANS is going to cause bronchodilation in your lungs, causing all of the bronchio to get bigger. So that way we can get more air in. When the parasympathetic division overrides it, when you're resting, it causes bronchoconstriction because you're not needing as much air as quickly. During allergic reactions, though, like we talked about last chapter, bronchoconstriction can occur, and this happens in asthma and anaphylactic shock. Okay, so where a bronchoconstriction can take place. Now again, this is just to show you that these are innervated by the autonomic nervous system. Fight or flight or rest or digest is going to determine kind of how your breathing is going to be affected. All right, so now we want to do a quick review of the tissues of the lungs. The lungs are enclosed and protected by the pleural membrane. This is, again, remember, a serous membrane that has 2 membranes. The parietal pleura is going to be the outer layer. This is the one that's going into the cavity. It's attached to the thoracic cavity. The visceral pleura is the inner lining, and it's the one up against the lung themselves. Okay, remember, visceral is against the organ, parietal is against the cavity. The pleural cavity is that tiny space in between these two, and it contains that serous fluid. So it has these two layers. Now, the pleura secretes that lubricating serous fluid that's called pleural fluid here, because we're specifically talking about the pleural, into the cavity. So it should have fluid. If air gets into this pleural cavity, okay, from the thorax, like from a thoracic wound or during surgery, this is called a pneumothorax. So you may have heard about a pneumothorax. That means air got into this layer where it should only have fluid. If blood is in this pleural cavity, that's either due to like trauma or a type of infection. It's called a hemothorax. Hemo meaning blood, and it's in this thorax area. If pus accumulates in the pleural cavity, this is normally due to a pulmonary infection. Okay, now again, all this stuff is going to inhibit that sliding, so then when you breathe, it's going to potentially cause issues. We also see pleurisy. Pleurisy is the inflammation of the pleura. This is where there's friction between there and it causes pain is the main symptom, again, when you breathe. Pleural effusion is an accumulation of fluid in the pleural cavity, okay, because there's too much fluid in there pressing on the lungs. This could be from an infection or from cancer. Now, we saw these two types of things even with the heart, with the pericardial cavity, okay, where we saw that there was pressure being put on there, or whether it was due to too much fluid or the friction. And you can see the same thing here with the pleural cavity with the lungs. All right, so let's take a quicker look into the lungs, where we're going to look at the bronchopulmonary segment. This is the segment of the lung tissue which is supplied by one of the tertiary bronchus, okay, a bronchi, the tertiary being the third. Each bronchopulmonary segment is made of many small compartments, and these compartments are called lobules, and you can see that here. And this is going to bring us to those terminal bronchi. And each lobule contains a number of things. All right, so it contains a lymphatic vessel, and this is going to allow for removal of extra fluid. It's going to have an arteriole and a venule. This is going to be the blood vessels again, so there's going to be a capillary that's going to connect these, and it's going to contain a terminal bronchiole. Lots of smooth muscle here, no cartilage, no cilia, because again, this is going to be for gas exchange. Now, each terminal bronchiole branches into microscopic branches, and these microscopic branches, which are super tiny, you'd have to have a microscope to see them, are what we call the respiratory bronchioles. These branch into several what we call alveolar ducts. Okay, these alveolar ducts you can see here that are going to have the alveolar sacs with them. Each alveolar duct bulges out to form several alveolar sacs of alveoli, and you can see it here in the picture. Now, this picture is found on page 854 in your book, and this is going to be on your exam, so you want to make sure that you take a look at this. There are certain structures you're going to need to know for the exam. You're going to need to know where the terminal bronchiole is. You're going to need to know where the respiratory bronchiole starts. You're going to need to know where the alveolar ducts are and the alveolar sacs, as well, of course, an individual one in the sac is called an alveoli. Okay, so you have these listed here, and I've circled them in the PowerPoint for you. Now, each alveolus is made of mostly simple squamous epithelium. Remember, simple means one layer, squamous means flattened. However, at the terminal bronchiole, you're going to see that it is simple cuboidal. So it goes from being cubes to the flattened. This simple squamous epithelial are type 1 alveolar cells. This is going to be the site of gas exchange. We have a really thin layer coming in contact with the capillaries, which allows for the gas to leak. So we have the oxygen going into the blood and the carbon dioxide coming out of the blood into the sacs. Some of the alveolar cells are cuboidal cells. The cuboidal ones, they do have some microvilli, those little small structures on them. These are called type 2 cells, and they secrete alveolar fluid for moisture and lubrication, because, guys, we don't want these air sacs that when you breathe out to collapse and stick to themselves. And so they have this fluid and stuff in them to help prevent that from happening. This alveolar fluid contains what we call surfactant. It's a phospholipid type structure, and again, it prevents the collapse to happen when you breathe out during expiration. Now, guys, there is a summary of all this stuff in table 23.1 in your book, found on page 857. All right, so now we've looked at the structure part. Now let's go look more at the functional part. What does it mean when we're doing our breathing? So with pulmonary ventilation or breathing, we're going to look at Boyle's law. Boyle's law applies to containers with flexible walls. Well, this is the case for your thoracic cage, for your thoracic cavity. Now, when we look at Boyle's law, it says the volume and pressure are inversely proportional, meaning it's kind of like on a seesaw. So when pressure goes up, okay, volume goes down. When volume goes up, pressure goes down. That's what inversely proportional means. It's kind of like a scale. When one goes up, the other has to go down. So if there is a decrease in volume, there will be an increase in pressure. And it's shown here in this kind of equation where V is inversely proportional to pressure, which means V, and then you have the 1 over P. All right, so let's take a look at breathing in versus breathing out. So with pulmonary ventilation, when we're looking at breathing for inspiration, inhalation, we're bringing air into the lungs. This occurs when the alveolar pressure, the pressure inside the lungs, falls below atmospheric pressure. Okay, so we see that the pressure is going to be lower here. The contraction of the diaphragm and external intercostal muscles increases the size of the thoracic. Okay, so the diaphragm is going to push down, and these muscles here are going to pull the chest out. Okay, increasing the size. This decreases the pressure inside the lungs even more. Okay, with this lower alveolar pressure, air moves down its pressure gradient. Remember, molecules like to move from high concentration to low, so high pressure to low pressure, so air draws into your lungs. Okay, that's inhalation. Okay, so elevation of the rib cage and contraction of the diaphragm draws air in because it lowers the pressure. Okay, because remember, if we're increasing volume, we're decreasing pressure, so it draws air in. Now, during forced inspiration, there's additional muscles that are used to help you be able to take a deeper breath in. This will be like the sternocleidomastoids. They can help you elevate the sternum and pull up. The scalenes will help elevate the upper 2 ribs, and the pectoris minors are going to help elevate the 3rd through 5th ribs. Again, increasing the volume, decreasing the pressure, allowing air to be pulled in to your lungs. Now let's look at expiration. Expiration or exhalation is where we're moving air out of the lungs. This occurs when the alveolar pressure is higher than atmospheric pressure. So we've pulled all this air in. Okay, so we increased volume and we pulled all this air in due to the pressure. Now pressure has increased. Okay, so now it's higher than atmospheric pressure. So we're going to relax the diaphragm. It's going to relax and push up. We're going to see constriction of the internal intercostal, so it's going to decrease the size of your chest, so it's going to move down. This increases the alveolar pressure, so air moves out of the lungs to the atmosphere, because now I have higher pressure here, lower pressure in the air, so air is going to move out. Now, during forced expiration, additional muscles can be used to push that air out where you're pushing the rest of the air out. So you have the internal intercostals are going to pull down on the ribs to push the air out, as well as your abdominal muscles. When you compress your abdominal muscles, the viscera will push the diaphragm even more up, which decreases this volume, increasing the pressure to push air out. So the pressure outside is less than the pressure inside, and we're pushing the air out of the body. All right, well, this brings us to looking at some terms that deal with breathing patterns. So eupnea is normal breathing, just normal breathing there. Dyspnea is labored breathing. So if you're having trouble breathing, it's dyspnea. Tachypnea is rapid breathing. Now tachy you should know because tachycardia is a high heart rate. Tachypnea would be rapid breathing. Coastal breathing is very shallow breathing. Diaphragmic breathing is deep breathing because that means you're using your diaphragm more. This is something you would use like if you have ever seen somebody who's a singer, or if you've been around where you've been training to sing. They talk about using your diaphragm and taking deep breaths in, and that's what it's talking about. Now, these different patterns are produced by different combinations of respiratory muscles. Of course, if you're doing shallow breathing, you're not using as many of those muscles versus if you're using deep breathing. All right, so it's a combination. I also want to talk to you about some modified respiratory movements, some modified breathing that we can see here. So when we have modified respiratory movements, they're used to express emotions and to also clear air passageways. So the first one is coughing. Coughing is to clear foreign particles from the larynx, trachea, and epiglottis, and so it's forcefully pushing the air out. We have sneezing. Sneezing is a stimulation or by an irritant of the nasal mucosa. Yawning, the exact stimulus is kind of unknown of why you yawn, because you know it can be kind of contagious when somebody else yawns, but it does kind of tied with drowsiness and fatigue. Hiccuping, guys, is a spasm of the diaphragm. It's where the diaphragm is actually having almost like a spasm or contraction, like kind of like a Charlie horse in a sense, but it's not as painful. Sometimes hiccups can be painful, but it's a spasm. This is stimulated normally by an irritation in a GI nerve ending, which comes closer contact with that diaphragm. We also see other modified respiratory movements might be sighing. So when you take that deep breath in and you go, that's a sigh. Sobbing or sniveling, like when you're really crying and your whole body moves and it affects your breathing. Just crying itself, and also laughing. Laughing is going to have a difference with your breathing. Also, we see there's one more listed here, and this is the Valsuvia maneuver. This is forced expiration without exhaling. So like when you bear down and you have that that's during like straining, during a bowel movement, or like labor and delivery, you get the air knocked out of you. Okay, that's kind of what we're talking about here. It's forced expiration without exhaling. Now guys, all of these are in a table. They're in a table found on page 861, table 23.2. I am going to pick a few of these and have them on your next exam. So you want to take a look at these in the chart and see like what does it mean when you sneeze, cough, yawn, that sort of thing. So pay attention to table 23.2 on page 861. All right, now we're going to talk about how we measure the volumes and the capacity of your lungs. Now, we did this in lab. You guys all went through the process of looking how a spirometer works. We used a water spirometer. You can also look online in Canvas in your lab shell, or in your lab area. You'll notice that there is a video about how you can see this on the graph, so you can take a look at that. You can also YouTube a spirometer, and it shows you all different kinds. But there are some terms we should look at. So when we're looking at spirometer and we are measuring volumes and capacities for your pulmonary function, one thing you want to see is tidal volume. Tidal volume is the volume of one normal breath. Okay, so just taking a normal breath, breathing in and out, is tidal volume. And this is about 500 mLs for each person. Okay, it might be a little more, a little less, depending on your age, your size, your gender, that kind of thing. Then we see that there's inspiratory reserve volume. Inspiratory, remember, means breathing in. So this is additional air which can be forcefully inspired or taken in. So this is again where you're breathing in, but then you go and you take a really deep breath. Okay, so this is in addition to the tidal volume. And this is approximately 3,100 milliliters. Approximately, again, it depends on age, sex, size, that sort of thing. The expiratory reserve volume is additional air that can be forcefully pushed out. And again, this is in addition to the tidal volume. And this is approximately 1,200 milliliters. So this is going to be the part where you breathe out and then you get that extra air pushed out. Okay, that's the expiratory reserve volume. Then you have your residual volume. This is the air which cannot be forced out of the lungs. Remember, we don't want our lungs to collapse because then they'll stick and we can't get the air back in. So there's going to be some air that remains in there at all time. We can't measure this with a spirometer, but we do know that it is approximately 1,200 mLs. And that's what we're going to use, is saying it's 1,200 mLs. So guys, pulmonary lung capacities can be calculated using 2 or more of these above values. So as long as you know a couple of these values, you can do some adding with it. We also see that there is a minute volume of respiration. A minute volume of respiration is the total volume of air that's taken in per minute. You can calculate this by looking at your milliliters per minute, where you take your tidal volume, which is approximately 500 milliliters, times how many breaths you take in a minute. Okay, you just sit there and you count them. All right, it might be 15, it might be 20, and then you multiply that by that 500 milliliters. This is going to give you your milliliters per minute. And again, you did this in lab. All right, just like in lab, you had this particular diagram. You have it here. You need to be able to read this. You need to be able to calculate different values based on this chart because it has numbers on it. All right, so if you look here at the very beginning, you're going to see that you have your tidal volume. All right, so you have your tidal volume that's going through here. This is going to be your normal breathing, and it's approximately 500 milliliters. Now, if we start and look over here, this is actually the start of the recording. You're going to see when you have your forced inhalation, you take a super deep breath in. That went all the way up to 6,000 mLs. But guys, when we look at the inspiratory capacity, you're going to look at it and you're going to say, oh, well, that's going to be the from 3,000 to 6,000, but you also have to take into account the tidal volume. All right, so you have to take into account the tidal volume, so you're going to look at that as well. You also see the expiratory. So the expiratory is this exhalation where you're breathing out. The extra expiratory you're going to see is located down below the tidal volume, and then they go back into normal breathing. Now, when we're looking at this, guys, you can add up some different things where you look at your inspiratory capacity. That's like how much you can actually breathe in completely, is going to be your inspiratory reserve volume, which you see here, plus your tidal volume. Okay, so it's that whole thing. So in this case, it's going to be about 3,600 milliliters. You can also calculate your functional residual capacity. Your functional residual capacity is going to be your expiratory reserve, which is located here. And you're going to also add it to your residual volume. Remember, that's about 1,200. And so that's the functional respiratory capacity. You then also have your vital capacity. Your vital capacity is where it's going to be inspiratory reserve plus tidal volume plus expiratory reserve. And you can see it's here. It shows you what you're adding together. And then last but not least, your total lung capacity is everything added together. All right, so you're going to add it all together. Now, guys, you'll notice there's a couple of different values here. The top value is what you normally see, especially in a man. The value that's in parentheses is what you see normally in women. And the big difference there is body size. The bigger the body, the more air that they're going to need to be able to take in, and the larger capacity they're going to have. So this is what you're looking at here with your lung volumes. All right, now since we're pulling air in and we're pushing air out, we want to also look at how the gas is exchanged. How do we exchange carbon dioxide and oxygen in this process of gas exchange? Well, we're going to see that there's some more physics involved. So we're going to see Dalton's law. Dalton's law applies to a mixture of gases because we obviously have a mixture of gases in the air that we're breathing. The pressure of each gas is directly proportional to the percentage of the gas in the total mixture. Okay, so the total pressure is going to be pressure of gas 1 plus pressure of gas 2 plus pressure of gas 3 plus pressure of gas 4 and so on. Well, that makes sense because it's the total. Okay. Now, an example of this, oxygen in the normal air you're breathing is about 21% in the atmosphere. So the oxygen in the air is about 21%. So the pressure of oxygen is going to be the 21%, which we have to put in a decimal, 0.21, times the pressure that's in the atmosphere. Guys, atmospheric pressure is 760 millimeters of mercury. All right. You don't have to memorize this. I just want to show you. So the pressure in the atmosphere of oxygen is only 159.6 out of that 760. Okay, so each gas is going to have a different percentage, which means it's going to have a different pressure. Now recall that these pressures are important because depending on if there's higher or lower pressure in a certain area, that's how they're going to move. That's how these gases are going to move. They don't like to be crammed together due to pressure, so they're going to want to spread out. So that's why these pressure numbers are important. So each gas is going to diffuse across a permeable membrane from the side where its pressure is greater to the side where the pressure is less. The greater the difference, the faster this is going to happen. All right, so if there's a bigger difference, you're going to see that it's going to move a lot quicker. Since there's a higher pressure of oxygen on the lung side of the alveolar capillary membrane, that's what the AC stands for, is the alveolar capillary membrane, oxygen is going to move from the alveoli into the blood. Okay, and we can see that here in the picture. It's moving into the blood. On the other hand, since there's a high pressure of carbon dioxide on the blood side of this membrane, carbon dioxide is going to move into the lungs. So it's going to do this simple diffusion, but guys, this diffusion, because it's a gas, is due to the pressure. Where is the pressure higher? Carbon dioxide pressure is higher in the blood, so it's going to move to the lungs. Okay, oxygen pressure is higher in the lungs, so it's going to move into the blood. This brings us to what we call Henry's law. Henry's law is the quantity of gas that will dissolve in a liquid is proportional to the partial pressure of the gas and its solubility. Now, guys, the big thing with this is pressure and solubility. How easily does it kind of dissolve into the fluid? Well, guys, this depends on a lot of chemicals. Hemoglobin is going to help trap that oxygen, so that's going to help it with its solubility. But again, the pressure is a big part of this. So, guys, carbon dioxide is 24 times more soluble than oxygen is. It is actually more soluble in liquid than oxygen is, so it is harder to get it out of the blood. Okay, because it likes to stay in there. And we see this like when you look at a Coke bottle. When you open that Coke bottle and it goes, ksh, pushed and it fizzes, that's the carbon dioxide in the liquid. It can stay in there and it stays for a while. That's why a Coke doesn't go flat just right away. Okay, it leaks out, but it does it slowly. So increased pressure is going to be put on the oxygen. We've got to push the oxygen because it's not going to want to go as easily as the carbon dioxide is. All right, so there's going to be normally more pressure on the oxygen side. So this is also why, guys, if somebody's having a hard time getting oxygen into the blood, that's why they put them on those nasal cannulas, okay, and they increase the pressure of the oxygen. So instead of breathing 21% oxygen, you're breathing 50% oxygen or 100% oxygen. That's going to force the air in there more so that you pick up the oxygen quicker. Okay, so that's what Henry's law is looking at. So you pick up the oxygen quicker, and that's why we utilize things like a CPAP, a ventilator, or even just a nasal cannula to help push the oxygen in. All right, just like we talked about last class, I want to review with you external respiration, which is the pulmonary side, and internal respiration, which is the tissue side. So in the external respiration, this is the exchange of gases between the alveoli and the pulmonary capillaries. So this is in the lungs. Oxygen and carbon dioxide is going to diffuse down their separate pressure gradients. So deoxygenated blood is low in oxygen, high in carbon dioxide. Okay, and this is coming from the right ventricle of the heart through the pulmonary trunk and the arteries. The alveoli, however, contain high oxygen and low CO2. So how is it going to move? The blood is going to gain the oxygen. Okay, oxygen is going to move from high to low, so it's going to move into the blood. And carbon dioxide is going to be lost by the blood, moving from the blood to the lungs, going again from high to low. Again, this is going to return to the left atria through the pulmonary veins and then go into systemic circulation. Now, this gas exchange requires a couple of things to take place. The first thing is we have to see that there's a steep pressure gradient. You have to see that there's a difference in the pressure, otherwise it won't move. High altitude, when you go up into like the mountains, there's less oxygen. There's lower O2, so the pressure is lower, and sometimes this is why it feels harder for you to breathe, or you feel like you can't catch your breath and that sort of thing. It's because there's not as steep of a pressure gradient. Okay. A large surface area. Those alveoli are sacs that allow for a large surface area so diffusion can take place. If the lungs are damaged by like emphysema, where there's decreased surface area, they're not expanding like they should and they're sticking together, then that's going to decrease the oxygen exchange because their surface area is hindered. There also needs to be a short diffusion distance. Guys, this is why the alveoli and the capillaries are almost pretty much touching each other. And it's a single layer of cells. It allows them to be able to be pushed the air back and forth. The problem is, let's say you have edema in your lungs, like due to pneumonia or something like that. That fluid pushes the tissues away, so the space is further, so oxygen cannot diffuse as quickly. So it's really important that all of these things be present, that there's a steep gradient in the pressures, there's a large surface area, and there's a short distance that it has to travel. Now let's look at internal tissue respiration. This is the exchange of gases between the tissues and the capillaries in the tissues. So again, oxygen and carbon dioxide still diffuse down their separate pressure gradients. So oxygenated blood is high in oxygen, low in carbon dioxide. This is coming from the arteries into the capillaries of the tissues. The tissue cells contain low oxygen, high CO2, because metabolism, they're breaking down the oxygen and creating carbon dioxide. So the blood is going to gain or take the carbon dioxide, and it's going to lose and send the oxygen to the tissues. Deoxygenated blood then is going to return to the right atria. Then you're going to go into external pulmonary respiration. You're going to then exchange it, and the blood's going to get rich with oxygen, and it's going to go back to internal respiration, and it's just a cycle going back and forth. So guys, how is all this respiration controlled? Okay, it's important to look at this and how it's controlled. It's controlled by your respiratory center in your brain. This is scattered groups of neurons in the medulla and the pons. So you'll recall back in chapter 14, we talked about how there were respiratory centers in the medulla and the pons. So there's three functional areas that we want to talk about. There's the medullary rhythmicity area. This controls the basic rhythm of your respiration, and it's located in the medulla. Inspiratory areas contain autorhythmic neurons for normal respiration. It keeps you kind of normal breathing patterns. The expiratory area contains neurons which are only active during forced or labored breathing. So they only come into contact whenever you really need to push that air out or pull it in, and additional muscles are needed, like when you're breathing, you've lost your breath, things like that. Okay, a pneumotaxic area. This is located in the pons. This sends impulses that limit inspiration and it facilitates expiration. So it prevents overexpansion of your lungs. It makes sure that your lungs don't get too full in that process. The apneustic area is located also in the pons, and this sends impulses to activate the inspiratory area in the medulla to allow you to breathe in. It stimulates inspiration and inhibits expiration. So guys, the pneumotaxic and the apneustic are opposites. But guys, if you look at the apneustic, it's talking about apnea. This should let you know when you're not breathing, when you're sleeping, so that's when you take a breath. Sometimes it doesn't happen and you have to have a machine to help you or something like that. But this area should cause you to continue to breathe. Now, respiration rate can be modified, and it can be modified by a number of things. The cerebral cortex can modify it, and this is a voluntary change in your respiration. So like when you want to hold your breath because you're jumping into water, you have the ability to do that. Okay. There's also chemical stimuli that can do this. Buildup of carbon dioxide. This is going to actually change the pH because it builds up an acid, and this will actually stimulate for you to breathe out by the medulla. Hypoxia, where you have not enough oxygen going to your tissues, can also increase your respiration rate. Severe hypoxia causes damage to the inspiratory center, which then makes it worse. So you don't breathe in as much, which causes you to get less oxygen, which causes you not to breathe in more, which causes less oxygen, and it causes a problem. And this is a big deal. So these areas in the brain really need to be able to get the oxygen they need to function correctly. We also see there's proprioceptors. They detect increased body movement. So when you are moving more and you're going to obviously be using more oxygen, you're going to see that your respirations are going to increase. Temperature. When you have a fever or the temperature is high, it's going to increase your respirations, whereas when you're cold, it actually decreases your respirations. When you get sudden sharp pain, it can cause apnea where you stop breathing. You know, when you get that sharp pain in your side and you go and you hold your breath, that's going to stop, and that's the apnea area. It's going to stop you from breathing. Prolonged pain, however, when you're in lots of pain, can increase your respiration when it's a long period of time. Now, this list can go on and on, but guys, it is talked about in your book on page 876 on table 23.3. So make sure that you take a look at that. Now let's talk about, we got the oxygen into the blood, but we need to take it to the tissues. And then we get the carbon dioxide into the blood and we need to take it to the lungs. So how is this transported in the blood? So guys, in the blood, about 1.5% of your oxygen is dissolved in the plasma as a gas. So it can actually travel through the actual just liquid without any help of hemoglobin. However, the majority of it, 98.5%, which you need to know this, 98.5% of the oxygen is carried attached to hemoglobin. That's the whole purpose of hemoglobin, is to attach oxygen and to carry it, transport it. Oxygenated hemoglobin is called oxyhemoglobin because it has the oxygen attached to it. Carbon dioxide, on the other hand, gets transported in the blood in 3 different ways. So oxygen, the main way is through hemoglobin, but in carbon dioxide, it's a little different. So 7% of it is dissolved in the plasma as gas. So remember, we talked about how carbon dioxide actually can be dissolved in liquid better than oxygen. Well, it's 7% of it is in this. 70% is converted into carbonic acid. It does this through the action of an enzyme called carbonic anhydrase. Now, if you look at this equation, you see CO2 plus water. The enzyme is going to convert this into H2CO3, which is carbonic acid. Okay, when we break up carbonic acid, it can create hydrogens, which is the acid part, and it has HCO3. Okay, so this is why, guys, carbon dioxide can alter your pH because it is acidic when it travels through the blood. Now, 23% of this carbon dioxide hitches a ride on hemoglobin. It binds to the same sites as oxygen. This is now called carboaminohemoglobin. So that way now that hemoglobin is saturated with carbon dioxide instead of oxygen. So please know, though, guys, that carbon dioxide is traveling in 3 ways, and these are the 3 ways: gas, carbonic acid, and hemoglobin. Now, guys, the amount of hemoglobin saturated with oxygen is called your saturation stat, or SaO2 stat. This is when they put the little thing on your finger or something like that, and they're looking at how much oxygen is getting to those tissues. Now, each hemoglobin molecule can carry up to 4 molecules of oxygen. Okay, so it can carry 1, 2, 3, or 4, but only 4 is the max. Okay. Now, the SaO2 is close to 95 to 98% normally, and this means hemoglobin is carrying the oxygen at its full capacity. When it returns, to your lungs, it actually still has 3 of the 4 oxygens bound in occupying the space. So when it goes 1 round through your body, it's only dropping 1 off. Then it goes back to the lungs and it picks 1 up. So it's keeping a reserve for itself. So guys, your SaO2 stat is still 75 when it gets back to your lungs, okay? Because it's only dropped off about 25%. So this is why when you stop breathing, as long as your blood keeps circulating, we can actually survive a while because you can still deliver oxygen. That hemoglobin then will go through the system again and drop off 1 oxygen. And now we went from, because it didn't pick up anymore, we went from having 3 down to 2. And then it can circulate again and drop off another oxygen and it goes down to 1. And then it can circulate again and then it goes down to 0. That's when it becomes a problem. That's why you can survive for a while when you hold your breath and things like that, because there is some oxygen still traveling through there. They're just dropping more off before they pick any up at the lungs if the lungs aren't delivering it. Now, this hemoglobin saturation is the percentage of heme units in the hemoglobin molecule that contain bound oxygen. And this can be affected by the environment as well. Hemoglobin can be affected because remember, hemoglobin is a protein. So the percentage of the pressure of oxygen of the blood, the amount of oxygen available is going to affect whether it can pick it up. The blood pH. If the blood is too acidic, it gets to where it can't hold on to oxygen as well. So this is why it's not very good for the blood to get too acidic. Temperature. Temperature is going to affect this. Okay. Increased heat is going to promote the release of oxygen, because normally when you have increased heat, your muscles are needing more oxygen to create more energy. Metabolic activity within the red blood cells. The more metabolic activity that you have, the more oxygen they're using as well. So you can see that this actually changes. Okay. Now this is why in CPR, guys, you only take a couple of breaths. You breathe for the person a couple of times and then you do 30 compressions. Because as long as you can keep the blood circulating, you can make sure oxygen is still being delivered, because the blood has reserve oxygen in it. All right, so transport of oxygen, carbon dioxide. Guys, as blood flows through the lungs towards the tissues, the increasing acidity of the pH, because they're picking up carbon dioxide as they go, shifts. And the oxygen-bound hemoglobin saturation starts to curve, meaning that it starts to unload the oxygen. It gets harder for hemoglobin to hold on to the oxygen because of the increased acidic pH of the blood. So when we look at this, as the blood becomes more acidic, hemoglobin has to release oxygen. So this is why in the lungs, because we're dropping the carbon dioxide off, the pH goes back up, okay, in the blood to about 7.35. And so it goes back up, which allows the hemoglobin to pick up the oxygen and hold on to it. As it travels through the tissues, the acidity starts to affect it because the pH goes down, and this is making it where it drops the oxygen off. Okay, this is called the Bohr effect. At the lungs, oxygenated blood has a reduced capacity to carry carbon dioxide. In the lungs, it has a harder time carrying the carbon dioxide, so it gets unloaded so we can exhale it. When we unload the carbon dioxide in the lungs, this is the Haldane effect. So guys, these are just telling you, when we look at the Bohr effect, that shows the shift of the blood in the tissues having a hard time holding on to the oxygen. The Haldane effect shows you the shift of them having a hard time holding on to carbon dioxide in the lungs. That way we are transporting them like we should. All right, guys, in your book on page 878 to 881, it talks a lot about different diseases and disorders, okay? So you see asthma, chronic obstructive pulmonary disease is called COPD, emphysema, chronic bronchitis, lung cancer, malignant mesothelioma. This is what you look at when you asbestos problems, pneumonia, tuberculosis, pulmonary edema, sudden infant death syndrome, which is SIDS. It's normally due to a breathing issue. We're not sure why, but they stop breathing. And severe acute respiratory syndrome, which is SARS. This is a type of infection that you see. I'd like you to take the time and read these, okay? On your exam, you are going to have a short answer about one of these. You're going to have a short answer about breathing, all right? So you need to make sure that you take a look at these, and you should spend really close attention looking at the asthma, the COPD, the emphysema, and the bronchitis, because all of those, again, are going to be a lot of times with breathing. Now, all of them are. Pulmonary edema is part of like a pneumonia, and it's part of emphysema, it's part of COPD, but I want you to take a look at all of these. Also, remember, treatment for a lot of these, when the breathing is getting constricted, is epinephrine, which we talked about last chapter with the immune system, because the whole point is if we get the epinephrine in there, it dilates the bronchi, so hopefully we can get more air in there. All right, but please take your time in your book and read about these. I'm not going to go over the diseases as much in this section or in the digestive or the urinary, but you are still responsible. There's going to be an essay question for each. There'll be a disease and disorder from respiratory, there'll be a disease and disorder from digestive, and a disease and disorder from urinary, and they are going to be essay questions on the next exam. So guys, I hope this kind of helps going through these notes. If you have any questions as we're going through this, if you're seeing any difficulty or problems with these, please feel free to ask me at the beginning of next class and I can clarify anything for you. You also have access to this video to watch it again and again if you need some help to kind of go over this. All right. But again, if you have any problems, let me know. A lot of this should make more sense with your lab because you've already performed the lab. All right. Have a great weekend. And I will see you guys on Wednesday. Make sure that you study for your quiz. Your quiz for lab is over the respiratory structures and functions. Focus in on lab 32. And we will be doing the digestive system lab in lab this week. All right. So have a great day and I will see you soon.